Hi, everyone. This is Lynn Crawford from Hope Dementia Support. And we are so fortunate to have Jamie Caulley here from the Providence system. And she will be talking to you about fall prevention in the home when you have a loved one with dementia. And Jamie, I'd love it if you could tell people a little bit about yourself.
Yeah, thank you for having me tonight. My name's Jamie Caulley. I'm a physical therapist with Providence, and I spent the 21 years of my career all at Providence so far. I've worked in a little bit in acute care and mostly in outpatient, so where you come into a clinic to see somebody. And I primarily work with older adults, some who have dementia, some who have other cognitive impairments, or other neurological impairments. And I do a lot, of course, with falls and balance, which is what I'm here to speak to today in the context of someone who has dementia. The other part of my role besides the clinic is with our senior health program at Providence, which is still a fairly young program, about 8 years old. And there's a handful of us that work on that team to improve care of seniors throughout our large medical system. So my role there is as a physical therapist as well, largely in fall prevention and some with dementia as well. I would love to hear who is in the audience, if you don't mind typing in the chat if you're a caregiver for somebody with dementia, if you're a friend or family member, or a professional working with people with dementia, just so I kind of know who's out there would be nice. I'll give us a moment for you to tap into your computer. And then Lynn, you'll bring up the presentation from...
I will. In fact, I can bring it up and we'll be able to look at the chat as well.
Sounds good. Oops. Oh, shoot. Oh, there we go. Never mind. I found my chat. I grew up in Hillsborough, Phyllis. My family still lives out there.
Is it built up like every place else?
Oh, yeah. Yeah, I get lost occasionally on my road. My family lives in downtown Hillsborough. It was quite changed to get there anyway. Okay. Anyone else want to share who they are and maybe what brought you to the presentation tonight? I'll kind of start talking, but I'll watch to see who's over there. This first screen is from the CDC's study toolkit on stopping elderly accidents, deaths, and injuries. And it's a self-assessment screening tool for somebody to check their own, kind of self-assess their own fall risk. We use it throughout Providence in our primary care clinics and our rehab clinics to also assess people's fall risk. So there's a copy of this in the handouts you'll get tonight, but I just wanted to introduce it here. You'll see this link below that says Falls Free Checkup from the National Council on Aging. That's a link that you'll also have in the handouts you get after the presentation, which you can share. You can send it to somebody else. You could fill it out yourself and it'll email you your answers. So it's kind of a digital version of this paper, or the screenshot you see of our paper version. Okay. Next slide, please. So this presentation I'm going to give tonight is part of one of our normal community talks that I give. Myself and our pharmacists and our other rehab providers give frequently throughout the different areas of Oregon and Southwest Washington. It's called Staying Healthy and on Your Feet. And tonight I'm going to present both kind of I'm going to give you a bit of the standard presentation, which is for kind of fall prevention for all older adults. And then we'll talk about specifics that are different for, or considerations for folks who have dementia. But all of the things that would help somebody with dementia prevent a fall are the same things that would help all older adults. And then there are some additional considerations. So we kind of want to make sure that the base things are covered that we would do for all older adults and then dive into the specifics. Next slide, please. So you'll get some handouts that include the slide deck with links in it, so you can still take notes, but you'll get all this information. That fall risk assessment that I showed. There's a home safety checklist in there that it's kind of meant for you to do on your own, and we'll talk about other home safety options. And then there's a list of medications that are associated with increased fall risk. And while that list isn't specific for persons with dementia, most of those medications are on that list because they impair cognition. So they generally are just as risky, if not riskier, for people with dementia. Next slide, please. So our goals today, again, learn what contributes to falls for all older adults, and then specific considerations for those with dementia. And then identify actions that you can take for yourself if you are an older adult or your loved one to decrease fall risk and keep safe and active. Next slide. So we do a lot of these community presentations on falls because falls really are a crisis across the United States. Every 20 minutes, an older adult dies from a fall, and of course, many more are injured. We can go on to the next slide. And those falls increase with age. So the older you are, the more likely you are to have a fall. And then some of the data you see here on sex and race and ethnicity are they could be skewed a bit by reporting. We're not always sure, but generally females report more falls than males, although males are more likely to die from a fall than a female. So there's some suspicion that females just report more falls or admit to more falls, perhaps. And then if we look at race and ethnicity, we see that Caucasian and American Indian Alaska Natives are the highest groups. Again, we're not sure we're capturing all of the data across other races and ethnicities, but that's what we know right now. And interestingly, the CDC is looking into why American Indian Alaska Natives have more increased fall risk. Next slide. Yep. So when we think about persons with dementia, they're even more likely to have falls than other older adults. They're at 8 times the risk of their peers. And unfortunately, they're more likely to have an injury or a fracture associated with that fall. They're more likely to end up in a nursing home after a fall, and the mortality or death rate from a fall is higher than for general older adults. So this is, it's a crisis for all older adults, but more so for persons with dementia. And when we just think about older adults, about 1 in 4 will fall every year, but less than half of them will talk to their healthcare provider about it. And I think this is twofold. One, we don't always ask as healthcare providers. We don't always like to talk about it either. Unfortunately. And then, you can imagine reasons why you may not want to share that you've had a fall. It's embarrassing, or you're worried about what it might mean, how you might be viewed, things like this. So even though we know people are falling, we're not having conversations about it as much as we could. Again, if we think about those 4 older adults, when we think about 4 people with dementia, 2 to 3 of them will fall every year.
Wow.
Yeah.
Let me go to the chat and see.
Oh, yeah. Can we go to the chat? So we asked.
Yeah. So you can see who these folks are.
Oh, yes. So it looks like.
Okay. So you saw Phyllis. Okay.
Let me enlarge this here. Yes.
So
Phyllis, Carol. Who works with Hope, it looks like. Is that correct? Jan, whose husband in Orchards, beautiful area. That's right.
You all right?
Yeah, I shouldn't try to drink water while talking. Janelle, I know, works with me at Providence. And Mike, it looks like you're caring for your mom at home. And I'm not quite reading that quite right.
So they are a couple. So Mike cares for mom at home, and Annette cares for mom at a memory care.
Gotcha. Okay. Gotcha. Yeah, you've got it on both sides. Claudia, home in Beaverton, for a couple of years. Okay. Tara, case manager, and Beth. Okay. But it looks like some of the HOPE facilitators also have a direct connection to dementia.
Sure.
Okay, thank you
Okay.
all for introducing yourselves. Okay, I think we can go on here. So part of why we talk about falls or want to talk about falls more is the cycle of falling. So you can see at the top that somebody has a fall and then they start to perhaps limit their activity. And then that makes it harder to move because they've become less active and less strong. And then they become perhaps more isolated. And then they might continue to lose more fitness and develop a fear of falling and then restrict their activities more. So this just kind of is a cycle that can perpetuate itself if we aren't able to kind of intervene and stop it in motion. So part of the point of giving these talks is to help intervene in this cycle. Next slide, please. Excuse me. So when we look at the risk factors that we know for falling, you see ones on the left that can be changed and ones on the right that we can't change. So luckily the list that we can't change is shorter. There is age, which so far we can't do anything about getting older. It's going to happen whether we want it or not. And with that comes some age-related changes. So we often wear glasses and our vision changes. We may need hearing aids. We lose some muscle mass and some quickness of speed. So some of these things are going to change regardless. And they contribute to fall risk to some degree. Chronic health conditions, we can't always change those, things like diabetes or heart disease, but we can manage them. And that often will help fall risk. Similar with severe illness or hospitalizations, sometimes these happen and they do increase fall risk, but we can help manage as somebody goes home and give proper supports to help mitigate fall risk. And then you see their memory and learning issues, such as dementia. We can't change the dementia, but we can manage some of the risk factors associated. And then over on the left, these are the ones we're going to talk about today that you can change. So we'll go ahead and go on to the next slide, but we'll dive into each of those a little bit further. So when we think about, those are fall risk factors that I spoke of to all older adults. When we think about those with dementia, the type of dementia that they have impacts their fall risk. So Lewy body dementia and Parkinson's dementias are more likely to have motor impairments, meaning difficulty with gait and balance. And so they are more likely to have more falls. Unmet needs contribute to falls. So if you think about your daily needs, you need to go to the bathroom, you need to eat regularly, you need to get up and move, you need to manage pain and have some socialization. All of these needs, if they aren't met for somebody with dementia, can lead to somebody getting up, to go to the bathroom when they need to, and it may not be a safe time to do so. Somebody's not there to help, or there's something, maybe they have a blanket around them that falls under their feet, something like this. So addressing basic needs does help mitigate fall risk. Sedentary behaviors associated with dementia, that lack of initiation and motivation to stay active. When we see neuropsychiatric symptoms associated with dementia, this is another increased risk. So agitation and aggression, wandering, these sorts of things. And some of those can be mitigated with some of those unmet needs, but sometimes they do create increased fall risk. And then caregiver fatigue, which is part of why I want to speak both to the fall risk factor for those that are caregiving, because taking care of yourself does essentially help you take better care of the person with dementia. So yeah, taking good care of yourself is a risk factor that you can address. Next slide, please. So some of the changes in movement that we see with dementia that make it more likely to fall, we see, of course, processing slow. And so we're less able to respond to a situation, especially if it's quick and needs a quick movement or balance response. We see attention and executive function decline. And executive function is that cognitive process that helps us regulate, control, and manage our thoughts and actions. helps us initiate things. So yes, if I need to go to the restroom, is it an appropriate time to do so is something that my executive function helps me decide if I should do it now or I should do it later. Our ability to multitask with dementia declines. So this is something I often talk to patients in the clinic and their caregivers about is if walking has gotten hard, somebody talking to the person with dementia while they're trying to walk can make it even more difficult because their brain is now trying to manage the walking and the talking. So limiting talking often for somebody who has mobility issues is helpful, turning down background music. And then managing an assisted device actually can increase fall risk in persons with dementia because now they're managing a cane or a walker as well as their body. And sometimes that is just more than the brain can attend to. And then this ability to adapt in an environment. So when something is unexpected, being able to react with good problem solving and good reaction speed is challenged in our persons with dementia. Next slide, please. Great. So I'm gonna, this circle is to kind of show all the people involved in reducing fall risk. So it's not on any one provider or any one person. This is certainly not all on your shoulders. There should be a team that is helping look at this. So in the center of this picture, you see the patient and their family. So in this case, our person with dementia and their family, and then their primary care team is that inner circle, which we'll talk about more near the end of the presentation. And then the outer circle is where we'll start with other health team members. Next slide. So we're going to start with vision, which is a component of balance. So some of the things that we can do to help reduce fall risk is make sure that our vision is as good as it can be. So having vision checked regularly. It seems so simple, but keeping glasses clean. I can't tell you the number of times I put on my glasses in the morning and think, I can't imagine how I was walking around with them this smudged yesterday. And again, somebody with dementia may not process that their glasses need to be clean. So it's something that would need to be attended to by a caregiver. Our eyes do not accommodate as well between light and dark. So when we go out on these nice sunny days and then come in, they take longer to adjust to the dimmer light and then adjust when we go back outside. So sunglasses or if somebody is a hat wearer, those things can help reduce some of that glare so that we can see better when we're transitioning. And then there is good evidence for treating cataracts as soon as possible and showing that does help reduce fall risk. Next slide, please. So a few vision tips, scanning a few steps ahead when you're walking for yourself. And then if you're walking with somebody with dementia, also to help them anticipate places their walking will need to change. And we know that some of the vision changes that happen with dementia can make things like puddles or shadows look like holes, or they can look confusing. So kind of anticipating some of those things and helping the person navigate those, or just guiding them around them if you know that they're going to be a challenge. Because vision field gets smaller with dementia, it gets sort of more like a scuba mask. Helping them note the wider environment, people coming from the side or cars or an upcoming intersection, and just kind of helping them take that in. And then that pausing when you're coming in and out of a place to let the eyes adjust to the light. And then at home, having good lighting in the house, particularly at night, of course. So night lights that are automatic versus ones that somebody needs to remember to turn on. High contrast on steps. So you see the little picture over on the right. You see a nice contrast between that red rail and the white wall. That's going to bring somebody's attention to the rail and help them use it with maybe less auditory or verbal cues. And then the stairs have that white edge, which can help just mark the edge of the stair so that they don't all blend together when we're looking down a stair. And then, of course, secure handrails so that there are things that can safely be pulled on or used to move. Next slide, please. Multifocal lenses can make it difficult to see obstacles and curves or changes in surface. This is most important usually for people who are active outside the house. There has been some evidence that using a single vision, meaning just distance vision glasses for outdoor activities reduces fall risk. It doesn't tend to matter as much in the house where the surface it's not changing, and we usually anticipate those changes better. But the reason is that multifocal lens at the bottom kind of blurs the change in surface when you're looking down through it to look at a step or a curb. Next slide. Okay, so moving on to another part of balance, which is our inner ear. Sometimes we call it the vestibular system in the medical jargon. It gives you an internal sense of where upright is. It can have problems as we age. It gets less sensitive, kind of like our eyes, but we can't slap a pair of glasses on it or treat it with cataracts yet. One of the problems that it does get is vertigo or a spinning sensation. This is often very easily treated, and it's very common as people age. The older you are, the more likely it is that vertigo that could be easily treated is present. So this is really something a primary care can treat or refer for, and physical therapists treat it quite a bit. So if you're noticing vertigo or disorientation with positional changes like bending, looking up, getting out of bed, or rolling over, that can be treated, and it can be very helpful in restoring balance. Hearing also affects our balance. It's not a primary sense, but it helps us kind of orient to where we are. So if you're walking outside, and you hear a car come up, it's less likely to startle you and require a last minute reaction because you heard it coming and you are aware of it. So regular hearing checks can also help prevent falls. Next slide. So of course, I would be remiss to be a PT talking to you if I didn't talk about exercise. Right? But exercise probably has the most evidence to prevent falls. And I'm going to talk about what ideal exercise looks like to prevent falls. And then we'll talk about a little bit more about specifics with persons with dementia. So ideally, all older adults would get, and this is all adults, middle-aged to older, would get 150 minutes a week or more of aerobic activity. So this is something that gets your heart rate up. You maybe get a little sweaty, you feel like you're working, and you're doing it for a sustained period of time. That 150 minutes can be broke up however you want, though, depending on your time, depending on your conditioning or fitness. And so some examples would be like walking, gardening, dancing, Tai Chi, or swimming. For somebody with dementia, a familiar activity will be best, something that they have always done or liked to do versus trying something new. So while Tai Chi, I'll talk about Tai Chi, and we'll try a few minutes of Tai Chi today. You know, if your person with dementia that you're helping caregive for has never done Tai Chi, that may not be the easiest thing to start. But if they were always a walker, or somebody who got out in the garden or liked dancing, and they're safe to still do so, those would be activities to steer towards. Next slide, please. So then, so that's endurance activity. We also want to have some strengthening, and this is to counter the muscle mass loss that we get with normal aging. And this strengthening is things, you know, that make your muscles work harder. We typically think of weights in the gym when we think of strengthening, but it can be body weights, it can be push-ups, it can be squats, lunges, things like this. You want to just be able to do about 8 to 12 repetitions before you feel like you need to take a break. And that means you're pushing the muscle hard enough. Some other examples besides weights would be like Pilates, yoga, or Tai Chi again. So again, thinking about somebody with dementia, something that is familiar is going to be good. So we use a lot of sit to stands from chairs, or squats. These are pretty familiar activities. Step ups, going up a step. Depending on somebody's history, there may be other ones like like push-ups or other kinds of weightlifting that might be appropriate. Next slide, please. And then the last component of a good exercise program is some balance training. And this is probably the one I think most patients that come in are missing, but it's something that challenges your balance and coordination. So yoga and Tai Chi are good examples. Dancing would be a good example. There are lots of balance, you can just do some more basic balance exercises that are part of a program as well, but something that uses balance and coordination to keep those reflexes sharp. In the end, however, the best exercise that you will do is the one for you. So while there's lots of good exercises out there, if it's not something you're going to stick with, it's not probably the best option for you. Next slide, please. So our feet are also part of course, what contributes to our balance. We know that older adults who go barefoot or in slipper socks or wear shoes without a back or a flip-flop, something that doesn't kind of stay connected to your foot, tend to have more falls. And most falls are multifactorial, so they're it's not just the shoe, it's usually the shoe and multitasking and a little weakness or that's an example, but it's kind of a combo of things. So as I'm talking through some of these, some of them are probably lower hanging fruit, meaning like, oh, it's really easy for me to wear a shoe with a back. Whereas some patients I see wearing, changing out of their favorite slip-ons is just it's not going to happen. So maybe thinking about which ones of these things that we're talking about today are possible for you or your person that you care for. So shoes that are good have a back, they fit your foot well, they're worn inside the house as well as outside. And they can be slippers, but they should have good traction, like an UGG style slipper that has a sole and fits the foot well is a good example. And then issues with pain can be addressed with podiatry to see if there are ways to reduce foot pain. Obviously, if our feet are painful, we're not going to want to move on them very easily. So that's how that helps us stay mobile. Next slide, please. Okay. So home safety, I mentioned there's a checklist that you'll get in your handouts, which is it's general, but it's fairly comprehensive, has you go room by room and kind of look at lighting and cords and setup. For somebody with dementia, really having an occupational therapist assess the home would be the most ideal, because they're going to have both the knowledge of the disease itself of dementia, as well as a myriad of different accommodations. So occupational therapists are very useful for home safety assessments. For yourself, I think that checklist can be helpful, and then kind of noting areas where the person with dementia might lean or might reach for, and making sure that those objects are stable. So you see in the picture some grab bars kind of by the back door. Many people will reach for like a door frame to step in, and those of course aren't meant to be pulled on repeatedly or bear our weight, but a bar mounted in studs is. And these could be, they could be brighter contrasted to really make them easily accessible for somebody to reach for instead of the door frame. Getting in and out of the tub. Many people use towel bars. These are not, of course, meant to bear our weight either. They're not typically mounted in studs. They're just meant to hold the towel. So if you're noticing somebody reaching for something like a towel rack, actually putting a grab bar in is a good idea. Next slide, please. We talked a little bit about the value of contrast steps to mark that edge. So that can be very helpful. Next slide. And then we talked a little bit about lights. So there's a lot of automatic lights, motion detected lights now that can just come on when somebody moves, making sure that all the areas of the home are lit. I live in a very old home, 1924, and surprisingly little number of outlets that people needed in 1924. So they make LED strip lights that even go along the baseboard and will light up as somebody walks if you don't have outlets. So there are a lot of different options for lighting these days. I think carrying a travel flashlight when you go to visit somebody is a good idea, so that you don't end up in a dark, driveway or situation where you didn't anticipate that can lead to a fall. Next slide. And then, just some general basics, keeping clutter out of common pathways, including pet items or grandchildren's toys. We already talked a little bit about stairs and handrails. The toilet is another place, that a grab bar would be commonly installed as a place that somebody tends to reach for something to stand up. Keeping cords, out of the way and coiled up so they're not going to get under somebody's feet. And then throw rugs. These are best just removed if possible. They tend to bunch up like you see there in the picture, or we can catch our toe on the edge of them, leading to a fall. A lot of people like their throw rugs and they're there for a very good reason. So using some double-sided tape if you don't want to remove the throw rug so that it really sticks and can't slip or bunch up or catch your toe is a good idea. Next slide, please. So pets, we all love our pets, but they do unfortunately contribute to falls in the home. So I know I've talked to a few patients who were thinking about getting a new puppy when somebody was diagnosed with dementia, and it may not be the best idea depending on their mobility and the puppy's mobility. But more falls are caused actually by dogs than cats, which is kind of surprising, but feels like cats are always whizzing between our feet. But dogs that can be trained or separated when somebody is moving can be a helpful way to try to manage some of those. And then of course going through and picking up pet toys, especially like before bed or sometime when somebody might be getting up and vision might be more limited. Next slide, please. So physical therapists, occupational therapists can be very helpful for people with dementia. We can, and those without dementia, we can help with exercise design, modifications, or recommendations if somebody is having difficulty exercising. We know that for exercise programs specific to people who have dementia, the ones that are successful are typically developed by a physical therapist or a skilled clinician that knows about dementia, and then supported by a caregiver. So somebody at home that can help them go, stick to the structure of the exercise and the setup of the exercise. We use different teaching techniques as therapists when somebody has cognitive impairment with dementia. So the way you and I learn without cognitive impairment, we often learn by our own errors. So if we go to stand up from a chair and we don't make it out of the chair, we kind of fall back into it. We're going to adjust how we get up. We might scoot more forward. We might tuck our feet under us. We might use our arms. We're gonna use something different because we got an error message. We didn't accomplish what we meant to. When we have dementia, people don't learn that way. So the error doesn't register that it needs a different approach. And often you'll see somebody commit the same error over and over. So one of the techniques we use is called errorless learning, meaning that we set the person up with enough cues and structure that they can do the task without the error. So we might tell them to scoot forward, tuck their feet under them, and then stand up. And we might do that over and over again until that motor pattern starts to kind of stick in the motor memory again, which it often does. Very familiar movements are easily retrained in this way, at least in mild to moderate stages of dementia. And then we can help with it, assessing whether a mobility device would be appropriate. As I mentioned, there are more falls associated with mobility devices for people with dementia than which is different than we think of for other older adults. But sometimes somebody can use one safely or with some cues from a caregiver. So we can help assess that if that's a question that you have. And then I mentioned home safety assessments by OT, but they also can do a functional cognitive assessment, often called an Allen cognitive level scale test, which is kind of a mouthful, but it basically looks at the patient's problem-solving abilities and then applies it to functional situations. So it gives very clear standards for, based on this assessment, somebody needs 24 hours supervision, or this person can be left alone for a few hours a day with access to phones and frequent check-ins or something like this. So it gives a lot of guidance to caregivers about what they can allow their loved one to do and what they really do need help with at this point. Next slide, please. And then we also have speech therapists. Speech therapists can help when there are communication deficits that need some different strategies. So if you're having trouble communicating with your person with dementia, a speech therapist can give lots of tips and tricks for that. In early dementia or mild cognitive impairment, they can help develop cognitive training programs, which can slow decline actually in mobility loss, surprisingly. Engaging our cognition helps us walk better. And if we combine that with actual physical exercise, cognitive training and physical exercise, we see larger increases in balance and ability to maintain walking speed. Next slide. This is a resource I wanted to share more for the caregivers or people without dementia, but this is a program that Providence runs called Strong for Life. It's developed for older adults to practice balance, endurance, and strength, those components of exercise we spoke of. There's a free on-demand video there that's linked that you can use, and it has seated versions, it has standing versions, and it has like a more dynamic like high level version. It was developed, we always said it was developed by physical therapists, I believe. And then there's also a DVD version if you prefer that. The contact information is there for that. Next slide, please. So Tai Chi, we're gonna take a few minutes and try some Tai Chi here in a second, but Tai Chi has the most evidence regarding fall prevention. After 12 weeks, done 3 times a week, it improves balance, improves strength, improves flexibility. It meets that aerobic or endurance activity. Classes are typically an hour, so it gets a lot of exercise in there, and it can reduce fall risk by half, which is pretty amazing. It can also help with anxiety and depression. It's helpful for managing pain with arthritis. It's weight bearing, but not aggressively dynamic. So it tends to be pretty tolerable with arthritis. And then it's also has a lot of evidence for patients with Parkinson's disease. The evidence in patients just with dementia is limited. And I personally have not yet found any Tai Chi instructors who teach for people with dementia, but if anyone knows something about patients or Tai Chi instructors who are geared towards persons with dementia, I'd be very curious to hear that as we have time at the end. Next slide. These are some Tai Chi resources. So we're going to try one of these videos, this first one in the bottom row that says free videos of Tai Chi with Suman Barkas. We're going to do a few minutes of that here together. Suman and this Tai Chi moving for better balance were developed actually in Oregon, down at Eugene. And moving for better balance is a type of Tai Chi that was developed specifically for older adults and specifically for fall prevention. It only has 8 forms of postures, whereas the standard form of Tai Chi is 108. So it's simplified, but high value. There's also a chair version link there, and then another just longer version by a different instructor that I linked. Our Providence Base Camp does a free in-person and streaming online Tai Chi class twice a week. There's a beginner and an advanced one. So for those of you who may not be able to leave to go exercise and need to stay home, the instructor is really great, and it's free to anyone. You don't need to be a Providence patient or live in one of our Providence regions. And then there's also some at the top, there's some DVD resources if those are more amenable to you. So I think next slide. I think this is the Tai Chi one. So we'll go ahead and pull the video up. While we're doing that, if you are unsure about your balance, I would say 2 things. You can watch a little bit and just kind of do some breathing and arm movements with the instructor. If you want to stand up and have your chair in front of you as something to just stabilize with, you can do that. If you're pretty confident in your balance, I would say give yourself a good like arm's length in forward, backward, and sides to be able to move. So we'll just listen to Saman here to describe a little bit about Tai Chi, and then he'll take us through a form or two.
What is Tai Chi? Tai Chi is a series of individual dance-like movements which flow smoothly from one form to another to make a sequence. When it is performed, Tai Chi brings together elements of movement, mind, and meditation, making it a mind-directed moving exercise. A long-term practice of Tai Chi effectively enhances the balance. This is because when you practice Tai Chi, you will respond to gentle demand on your posture's stability. This low-intensity therapeutic exercise improves the strength and balance. Tai Chi is a safe way to exercise. To be sure to prevent injury, control body posture, and be safe during each of your practice sessions, please be mindful of the following safety tips. If you have any doubt about your physical condition, stop practicing Tai Chi. If necessary, call your doctor for the consultation about continuing exercise. If you have a history of knee problems or arthritis, do Tai Chi with a high stance to reduce the pressure on knees. Always begin a practice session with warm-up exercises and end your exercise session with cool-down exercises. Always take small or comfortable steps in performing each movement. Also place the leading foot lightly on the floor to prevent the foot injuries. Carefully listen to your body while exercising. Take as many breaks as needed during practice sessions and drink plenty of water. Before starting basic 8 movement practices, it is necessary to do warm-ups. Next warm-ups. Swing arms in front and back. Turn and twist. Twisting. And next warm-ups are swing arms. Side to side. So relax your arms and soft lifting up, dropping down. Lift your arms up as far as you can lift your arms up, and pressing hands down and push backward and repeating several times. Inhalation, lifting arms up, exhalation, pushing the hands back and bending knees and hips. Step aside, shifting weight, side to side. And stepping out front, heel, push hands backward, stepping back, lift your arms upward, repeat. As you shift your weight on the other side, step out, switch. and bending knees, shaking and loosening up, knees, shoulders, arms, and ready for the 8 movements. Begin with the centering stance, feet together, arms at the sides, letting breath be regular, slow, and deep, relaxing the mind, letting posture be upright with the head light, spine long, and the chin tucked slightly in. Step out to shoulder width. On inhale.
There's one simple exotic herb that anyone can use to flush out nail fungus almost overnight. Did you know that nail
We
fungus?
go ahead and stop there. There's one problem with YouTube, right? They started putting them in the middle instead of at the beginning. But hopefully that gave you a little bit of, you saw a little Tai Chi from Suman there at the beginning, and then we did a little warm up, which I think sometimes the warm up is just as delightful as the actual Tai Chi. It's really nice to do, but quick and easy to do from any location for the most part, and you don't need any equipment or anything. Okay, let's see. We'll go back to our presentation. Has anyone that's done Tai Chi in the past? Okay. Okay, let's see. Sorry, let me just reestablish. There's my chat. Okay. Oh yeah, Qigong is pretty similar. Lots of similar benefits and very approachable. Thanks, Carol. Okay, so this slide, that's correct, Lynn. This one is where we should start. We talked about this outer circle with vision and taking care of our feet and our home and strength and balance, and the people who can help with those issues. On the inside, now we're going to talk about this inner circle that refers more to the primary care team and how they can be helpful. Next slide. So the first good thing to do is talk to your primary care provider about falls, whether for yourself or for your person you're caregiving for with dementia, and ask about medications and their fall risk if you know that mobility and falls are an issue for you or your person with dementia. Helping keep track of falls or near misses in falls. Near misses can sort of indicate to us that there's a problem brewing, and so it's a good opportunity to start to have conversations and look at what maybe we can change. And then falls happening, if they're around when somebody takes a medication or a certain time of day or a certain situation, that can help kind of hone in on some solutions. Making sure, of course, to have an updated medication list and reviewing it with your primary care or prescribing providers at least once a year. As we get older, our body processes medications differently, and so even if we've been on a medication for a long time, our body might be processing it and need a different dose, or maybe not respond as well to a medication over time. So it's always worth looking at medications on kind of an annual basis. And then generally 4 or more medications, which I know is not, as we age and get multiple conditions, is not a hard number to hit. But more than 4 is associated with increased risk of falls, just due to a lot of the interactions of the different medications. Next slide, please. So these are some categories of medications that are high risk, and it doesn't mean that we don't use these medications and use them with good need, but they should require some kind of analysis for us and the prescribing provider if somebody is at risk for falls. So most of these medications increase fall risk because they slow down reaction time, or they lead to confusion or dizziness, or they lower blood pressure. And we'll talk a little bit more about low blood pressure coming up. But some categories are some over-the-counter medications, which is always a little surprising. We kind of think if you can just buy it at the store, it should be fairly safe. But anything with PM in the title, like Advil PM or Tylenol PM, these have sedating properties that can contribute to slowing down and confusion, which is of course how they help people sleep, was the PM part of them. But they should be avoided in people with increased fall risk. And then things like Benadryl that also can be sedating and cause confusion should be limited or avoided. Other categories, pain pills, specifically there's a few examples on each of these, not a comprehensive list, but a few of the most prevalent medications that you might see. Sleeping pills, as you might imagine, things that help us go to sleep, sort of sedate us and make us move slower or groggier. So they generally contribute to fall risk. A lot of the older medications for anxiety or mood tend to contribute to fall risk. And as well as some of the muscle relaxants that relax they relax our muscles often, and often we need, when we're prescribed those, we need to have our muscles relaxed due to pain, but they also therefore contribute to fall risk. Alcohol's on here. We'll talk a little bit more about that in a minute. And so I think just when you review your medications or your person with dementia's medications, asking, is this one still needed, and do I still need this amount of it? Because sometimes, these things just get kind of piled on, and they aren't always as thoughtfully prescribed or managed as we might hope. Next slide, please. So best practices for when you are taking a high risk med or thinking about a high risk one, if anything, high risk can be stopped or isn't needed or isn't doing what it needs to be doing, talking to your provider about stopping that. Switching to a safer one if that's an option. So an example that our geriatricians use a lot for persons with dementia is like scheduled Tylenol for pain versus an opioid. And that's true for all older adults really, but the scheduling of the Tylenol or for pain control can be very important for somebody with dementia who may not be able to, take the medication. If they only take it when they have pain, it's kind of too late. They're already painful, they've fallen, they're agitated by the pain, something like this. So the scheduling of that really is useful. And then if a medication can't be stopped or there isn't another option, but it's needed, talking to your provider about the lowest dose that can be effective for you. Next slide, please. Alcohol is a drug, and I think we're all aware it decreases coordination, mobility, balance, reaction. So it generally increases fall risk in that way. It can worsen a lot of other health conditions that you see there, and about half of all drugs interact with alcohol. The World Health Organization recommends a maximum of 2 drinks a day for men and 1 for women. And a drink is pictured over here on the right. So, these sizes are not always what is mainstream anymore. So a serving of beer is just 12 ounces. So it's 1 regular can or bottle. A lot of the beers that you might see in the store now come in 16 or 20 ounce cans or are served that way in the restaurant, which, is at least a serving and a half. Same with wine. The wine glass, they're big goblets often so that we can smell the wine and enjoy it, but 5 ounces is actually a serving. So if we're filling a wine glass, that is way more than a serving, and that's pretty common thing that can happen. And then with liquor, it's a shot, so 1.5 ounces. So just being aware that if you or somebody with dementia is having alcohol, that we're keeping these portions in mind, and we're keeping the increased risk in mind and balancing that out. Next slide, please. So some other strategies for reducing fall risk for persons with dementia in the daytime, anticipating needs. So scheduling snacks, scheduling movement, kind of knowing, the needs that the person with dementia had before developing dementia are still present, and they still need to be attended to. They may not be able to vocalize them well, so we have to kind of be good rememberers and detectives about what somebody, like for myself, I don't sit still very often, so I would need a lot of movement for whomever was caregiving for me. And some people need more movement, some people need more socialization, kind of depending on what our personality was and is. So ensuring activities and exercise, particularly in the morning, getting outside in the morning and getting that normal light can help us regulate our normal rhythms and help us kind of orient to day and then night more easily. Limiting naps to make sure that somebody does sleep well at night, particularly if they're not sleeping well at night. Managing pain proactively versus waiting till it comes up in somebody who has dementia. And then scheduling nutrition and hydration to make sure that they're getting enough and we're not waiting until somebody is hungry or thirsty that can result in other behaviors. Next slide, please. For nighttime, again, anticipating needs. So scheduling toileting before bed. If somebody tends to need to get up at night, maybe offering that so that versus them getting up and then, fumbling with the light or tripping. Managing pain, of course, if pain is relevant to sleeping. There are some other topical muscle rubs that are generally pretty safe. Heating pads, stretching before bed. Some of these things can help. Maybe a nighttime snack if somebody tends to get to wake up hungry and get up and wander into the kitchen. These night lights we spoke of that come on automatically with clear, free pathways to the bathroom. And then limiting time in bed so that somebody isn't staying in bed longer and kind of getting their cycle further out of alignment with norm. And mimicking their prior sleep. So if they were a late night person before, it might make sense to keep that schedule if possible, or some version of it. Or if they were early to bed, then kind of trying to stick with some of these pre-dementia preferences. Next slide, please. So I mentioned blood pressure. There is a term called orthostatic blood pressure, which is a term we use when blood pressure drops when we rise. So normally when I stand up or get out of bed, my blood pressure goes up a little bit because now it has to pump against gravity harder, and it needs to get all the way to my brain. So that response diminishes a bit with normal aging, and we can see more trouble with that. So sometimes somebody stands up and their blood pressure doesn't go up and they feel lightheaded, dizzy, or just sometimes they're off balance. Some medications can aggravate that condition. And we mentioned this in our regular falls talk to older adults, but particularly for people with dementia, especially Parkinson's or Lewy body dementias, about 50% of unexplained falls are thought to be associated with some kind of orthostasis or nearly passing out from low blood pressure. So this is something that your provider can check or any health professional can check for you, or you can check at home just by taking a blood pressure laying down and a blood pressure standing. And it should go up when we stand up. Next slide, please. So if blood pressure does drop, of course, talking to your provider or pharmacist to see if any of the medications are affecting it, changing position slowly and reminding somebody with dementia to do that. Sometimes sitting at the edge of the bed, kind of, pumping our feet and squeezing our fists can kind of get some blood flowing and some pressure up before we stand up. Making sure we get enough fluids is important for keeping our blood pressure up, because if we're not hydrated, we don't have enough blood volume to get our pressure up. And then limiting those fluids to earlier in the day so that you're not having to get up so much at night. 50 to 60 ounces of non-alcoholic, non-caffeinated fluids per day is ideal for most older adults. Next slide, please. So vitamin D, we'll talk about vitamin D and calcium. These are both helpful in reducing falls in that they help keep our muscle strength up. They help reduce the risk of falls and fracture. It's a good idea to talk to your primary care about what vitamin D level is appropriate for you or for your person with dementia, but generally a minimum of 1,000 to 2,000 units per day as a supplement is needed, especially here where we, for many months out of the year don't have a lot of sun. The goal is 4,000 across all sources, supplements and food, but vitamin D is not available in a lot of foods. However, calcium is much easier to get from food and supports vitamin D in supporting our muscles and our bones. So you can get most of it from your food. And then if you need to take a supplement, you're aiming for about 1,200 milligrams across all sources per day. Next slide, please. So osteoporosis, this is a condition where our bones start to become less dense and they get more fragile and break. There are no symptoms of osteoporosis, so it's something ideally health professionals are screening for in older adults. However, it's often something that gets missed, and more so in persons with dementia. Amongst all the other screenings that we do, this one, we haven't gotten all the screening down yet. So men and women can get osteoporosis, though it's more common in women. Vitamin D and calcium can help with prevention and management, as well as weight-bearing exercise. And then there are other treatments if osteoporosis is identified to talk to your healthcare provider about. Next slide, please. Okay, so we're at the end of my formal presentation. I'll just remind you to go back when you get the handouts tonight and do this self-assessment screen. It is validated in older adults. It is not validated necessarily for persons with dementia, although we use it a lot, sort of what we call by proxy. So a caregiver will fill it out for a person with dementia. We don't have specific fall risk screens validated yet for people with dementia. So this is sort of our best, a caregiver filling it out is kind of our best estimate so far. But it has many of the fall risk factors we talked about today, and then why it matters. And hopefully with the material you gathered today, you learned some things you can do about those specific fall risk factors for yourself or your person with dementia. Next slide. So I, again, like to remind people that we talked about a lot of things, but sometimes it's overwhelming. But thinking about which ones are easier to start, like scheduling a vision check or switching out shoes, installing that handrail you've been meaning to, these kinds of things, like what can you kind of start with, and then what is harder? Maybe often exercise is one that falls into the harder category if it's not something that someone's currently doing, but kind of starting small and working your way up as you think about the addressing risk. All right, I think the last slide. Yep, thank you for listening. I will head to the questions in the chat, Lynn. Is that a good place to go next? Let's see, I'm gonna just scroll back a little. Okay. Let's see. Okay, I'm back kind of where comments have started. So Carol, yes, taking off your glasses to step down, that can be a strategy. Just taking them up so you don't get that distortion. If your vision is good enough to do so. Let's see, Nanette had a question about a bed rail. Bed rails, they can be good, they can be bad. is the answer there. It sort of depends. I think that's one of those, if it's for somebody who has dementia, I would have an occupational therapist assess and recommend which one should go. You want it to be mounted well enough to the bed that it can't be pulled on in the wrong direction and pulled out. And that's true for all of us, but more so with somebody who has dementia and the cognitive impairment with that. They also use often what's called a super pole, which is a floor to ceiling suspension mount. It can be mounted anywhere, but it's just a vertical straight up and down pole that you can put next to a bed and is meant to be pulled on to stand, to roll over, these kinds of things. And that can sometimes be more secure than a side rail. There is some, depending on who somebody sleeps with, if they're sleeping with somebody, the side rail might be okay, but sometimes somebody is sleeping alone, they can kind of get trapped by the side rail a little bit. And so that's something we'd want to avoid. So I think I would probably have an occupational therapist look specifically at the person and their bed and their situation and make a recommendation. Let's see, is depth perception a problem? Yes. I mean, it's a problem. It decreases for all older adults, but certainly the visual changes with dementia do make depth perception harder and harder to identify what we're looking at. Is it a hole or a puddle? The shadows are harder to decipher what they are and how deep they are, similar with stairs. Let's see, Carol said, walking backwards shown to boost your memory. I have not read that study, but yeah, I think there are starting to be some walking backwards tests. And I believe actually, they sometimes they don't pay 100% attention to all the new tests until they get validated a little bit. But I think there has been some tests for walking backwards as a screening for dementia as something that gets limited. So I bet, yeah, I think things that help keep your brain thinking and active physically also help our memory, and vice versa. As I mentioned, things that we do cognitively can also help us in a physical way. Let's see. Oh, does a heating pad cause a burn? I guess it depends again. Most heating pads can be set with an automatic off switch. They should never be placed right on somebody's skin, but they usually come with a thicker cover. So if that's on and an auto time off, usually 20 minutes is a good rule of thumb. It shouldn't, but if it's an old heating pad or the cover is missing and something else is being used, yes, I think it could. So it kind of depends on the status of the heating pad. They should be monitored, right? We should put a heating pad on somebody with dementia and not have an auto timer or be checking their skin, of course. Let's see. Carol says, good info. I think I need a handrail outside to step in the front door. Yeah, that's a really common place, especially, we're stepping in often with things, right? Groceries, things we're bringing in from the car. So having something mounted there that's really stable is a good idea. Yeah. Tara says, so frustrating how many aging folks are prescribed multifocal lenses without warnings of fall risk. Oh, how can this be changed? Easy doesn't mean safest. Yeah, it's interesting. I think this is still a gap in knowledge between the geriatric providers and optometrists. And glasses are expensive, so to have multiple pairs sometimes is not realistic for everyone. I think, yeah, at this point, I think until we kind of get all our health professionals caught up, letting optometrists know that somebody is a fall risk, and asking about a single distance pair, or if you're noticing difficulty. Some people don't notice as much difference with if somebody's had progressives their whole life. Sometimes I don't see a big difference if they do move to a single vision. So I think it's still a case by case basis, but I do admit I don't see a lot of optometrists recognizing that risk yet.
I would have to say that I've worn progressives forever, and I don't notice that. They always say when you start wearing them that you will, to be careful. And I've never noticed the difference.
Oh, that's great. Yeah, your brain just adapted probably, and you move your head to the right place so that you don't get it. I see it more impairing just in patients when the brain isn't working as well and it's not taking them to that auto place where their head needs to be to see correctly.
Okay, I have a bunch more questions that didn't show up on the chat.
Oh, great. Okay.
So what if there are a lot of falls and the caregiver has to call for help every time? And what if a care facility is outside of the family's ability to pay for it and the fall risk is high at home? These are what ifs.
Yeah. So let me make sure I understand right. Like an example that somebody lives in a facility where the caregivers have to call every time there's a fall. Is that but the fall risk is also really high at home, so there doesn't feel like a good option.
Well, I really think the issue is that we hear this a lot in our support groups. One of the things that we've noticed by having a support group for people with dementia is that they all have balance issues. And I don't think I ever really paid attention to that until I was in a room with 12 people with dementia, and that they all have balance issues. And often they're elderly people and their spouses are elderly and they can't get them up. Are you aware of options for tools to get them up, or ideas or suggestions?
Yeah. I mean, of course, I think a fall, and not in the exact moment, but later, a fall is a good opportunity to look and see, are there things we could do to mitigate this next time? Not all, I mean, as dementia progresses, we most likely will not prevent all the falls, no matter how hard we try. It just, the disease makes it challenging to do that. But so when somebody does fall, I think a couple things. One, in physical therapy, if the caregiver and the patient still have decent mobility, but aren't quite sure how to get up safely together, that's something we can definitely teach. Strategies, often bringing over a chair, somebody can push up with their hands, or we may be able to use like a gait belt for a caregiver to help a little bit. Of course, this depends on the person with dementia and their caregiver's physical abilities. They make a device called a Hoyer lift, which can be used to lift somebody from the floor. It's a hydraulic lift. So it requires just putting a sling under somebody. So a little bit of rolling side to side to get that under. And then most caregivers would be able to operate the hydraulic lift to lift them back up into a chair. So if somebody is falling a lot, but not getting hurt, not needing medical attention, that might be a good option. And that's something that could be ordered from the primary care or a therapist, physical or occupational therapist. And typically one of those therapists would come out to the home to show you how to use it properly. And then the fire department, as I understand it in most areas, is willing to come help people up, and then assess, is anything else needed medically, or do we just need help up from the floor? So that's another option with your local fire department. Anyone else have good? I certainly don't. I don't have all the answers to those questions. But does anyone else have thoughts that's on today or experience?
I know there a couple of our group members have found tools that are like an inflatable thingy that they can get underneath them, and it kind of helps them get into an upright position so that they can help them get up, as opposed to a flat position. But I haven't seen it, so I'm not sure exactly what that is.
I don't know what that is either. I'd be curious. Be curious to know.
So another question is, where would you find these classes? The ones that you have mentioned.
Oh, the community fall risk classes?
Yeah.
Yeah, that's a good question. We we do them all over the Oregon, Southwest Washington area. Right now, I can share, Lynn, I'll share with you a flyer we have of upcoming ones. In the near future, the senior health program hopes to have an external site, which I would love to route you to, but it's not up and running yet. So we're still doing it with old school flyers and word of mouth and that sort of thing at this point. But I'll send you the flyer that we have for the rest of the year for our talk.
Great, thank you.
Yeah.
Would you recommend that the individual who has had a fall tells their PCP about it? They're embarrassed, they don't like to talk about it. But do you feel that it's important to have that conversation because they don't want to be labeled, unquote?
I think it's important to have the conversation, and sooner is better because usually we can do more about fall risk when there's just a few factors versus sometimes when somebody's been falling for a long time and more of that cycle of inactivity and fear and all of these things have sort of compounded, it gets much harder to change. That said, it's not an easy conversation, I think, to have. And you know, providers, admittedly, some providers are gonna have lots of input and feedback. Some may not know what to do themselves. So that's part of why sometimes providers don't talk about it, is because they don't know what to do about falls either. So that's part of my role at the senior health program at Providence, but it is possible that somebody gets up the courage to talk about it and then their provider might not know. So it may be, you know, continuing to look for the providers that know. Physical therapists, occupational therapists should be pretty knowledgeable in that area. Geriatricians, of course, would be knowledgeable in that area, but finding people who do have ideas and productive, positive inputs for it would be good. But yeah, if we don't talk about it, then of course we can't do anything about it. And then it typically, you know, has a trajectory that is worse. So I think it is worth talking about, even if it's hard conversation.
So how do we get an occupational therapist to assess our home? Is there financial or physical help to fix or add things that they recommend?
Yeah, it kind of again, I feel like everything depends. So options for home assessment would be if somebody is homebound, meaning they're not safe to leave the house by themselves, then they qualify for home health to come out. I don't know if this is different in Washington than Oregon. In Oregon, they still have to have a physical therapist or a nurse come out from home health for OT to come out. So it may be that you have to have PT and OT or a nurse and OT come out. But if somebody's homebound, then they qualify for a home safety assessment. Many times a home safety assessment can happen as a one-time visit through somebody's insurance, even if they're not homebound. They just may not be able to come out multiple times. And then there are a few private organizations that OTs run where they can bill insurance just through a private OT. What's the word I'm looking for? Business, I guess, is the sort of a mobile clinic, and they often are billing under the. This gets a little technical, but billing under Medicare Part B. So Part B rules are for outpatient, like somebody coming into the clinic. There are some clinics that are set up to go anywhere. They can go to the house, they can go to the golf course, they can go to the gym, and they bill under those Part B rules, but they're more mobile. So that would be another option if somebody's not homebound.
Is there a recommended spectrum of lighting?
Oh, you know, I've been asked that before, and I know I've asked my OT colleagues, and I'm not going to remember the answer, unfortunately.
Well, there's a comment
say it's full spectrum.
Yeah, that fluorescent lights are difficult on the eyes. Is that
Fluorescents are definitely difficult. I want to say it's full spectrum lighting that is the easiest on eyes with the least glare. But yes, fluorescents are glary. They have a little flicker to them, which our brain has to filter out for us, but doesn't do as well when there are other factors like dementia or other dizziness or other things can make that harder to filter out. So yeah, if you're in, you know, of course, all our medical facilities tend to have fluorescent lighting. So it's a good place to wear a hat if that bothers you, or the person with dementia, and they're amenable to hats, or some of my patients that it really bothers wear sunglasses, just a very light shade of sunglasses or colored glasses into the clinic, to reduce some of that.
Can you describe a little bit more about the assistive devices and people with dementia?
Oh, yeah.
The reason
Well,
I mention it is because my husband had dementia and he would pick up the walker and walk with it. He could not understand how it was to be used.
Yeah, so like I said, it is assistive device use, like walkers or canes, can be more associated with fall risk because they do require often new learning. So if somebody used a cane before getting dementia, they most likely retain some of those skills to use it, and it might be more useful. But if they're trying to learn to use it with dementia, the brain is now trying to, to navigate walking, which has gotten hard, and this new learning with this new device. And that sometimes is just more than the brain can manage. So it becomes more of a trip hazard than it does a help. So sometimes just a handhold assist with a caregiver, like, let's see if I can do this with a hand. I wish I had a different hand, but just by that kind of a hand over hand, walking next to somebody can be more helpful. So they can kind of push into your palm just a little bit. And you're kind of walking right next to them and able to kind of guide them with your hand in a direction, versus when they're moving with the device too, you're going to have to steer them, towards different directions verbally, which sometimes can take a little bit longer to process.
Okay. So if we felt that we wanted to have OT, PT, or speech come out to help us, do we need a direct referral from a physician?
Yes. So your primary care provider could order home health to come out, and they there's a few rules. They usually need to have seen the person in the last 60 days, and they typically need to be homebound, or it's, like I said, a one-time visit. But yes, primary care would be the place to start for a referral.
Okay.
Yeah.
A comment related to medication is that my mother used to sleepwalk, although she appeared awake and alert when she took Ambien. So I think that is just a comment about medication.
Yeah. Okay. And Lynn, I don't know, but I know you and I had planned to do this talk last year, and then I had to cancel on you at the last minute due to getting COVID. But I think I mentioned then, we often do these community falls talks with a physical therapist and a pharmacist, and because we do those for like a 2-hour event. So if you were interested, I certainly could connect you to our pharmacist who could speak more to certain medications and their effect in specifically in people with dementia, more so than I presented on today. But that sort of Ambien is definitely out of my scope of knowledge.
Well, a couple of months ago, we actually had a physician talking about medications and dementia.
Great.
So,
okay. So you got that.
And then there is a comment here, the easy lift up lifting cushion weighs only 5 pounds. Its 3 chambers are made of a durable and easy to clean material, because she Googled it while we were.
Okay. Thanks, Carol. I will look that one up. I'm not familiar with that one, but it's always good to know. There's always new things being invented, some of which make our lives easier.
Well, Jamie, thank you so much. This was very helpful.
Good.
And we always have more people sign up than attend, but the nice thing is it's a recording and we send it out to everyone. So everyone that intended to attend will receive this information, and hugely helpful. Thank you so much.
Yeah. Thank you so much for having me and all the great discussion. I'm really impressed with all the questions that people brought forward in discussion.
All right. Thank you all. Next month, we will actually have Mary Grace Becker from the University of Washington talking about dementia-friendly communities, the Seattle experience. And as we are trying very hard to create dementia-friendly communities here, I hope everyone can attend. So thanks again, Jamie. We appreciate it.
Yeah, thank you. Good night.
Bye-bye.